Yes.
She did? Okay, okay, then I won't bore you with that any further. Any questions?
Does anyone have any questions? Counselor Buzzard?
George, can you just give a brief overview of the denied and deferred?
Deferred services are ambulatory services that have not taken place yet. If you need to go out to a visit, that would be a deferred services, and if it hasn't happened yet. The denied service for us is something that's already happened, like an ER visit. You've already had the service, you've already had that, and then you call it in to be considered for payment. That would be a denied. If it was turned down, that would be a denied as opposed to a deferred service, something that hasn't happened yet.
Okay, and it's the same if we went to a private doctor or hospital?
Yes.
That would be denied.
Yeah, as long as it's already happened, they've already received the service.
Okay.
It's denied.
Okay.
Yes.
I was a little bit maybe confused on it. I thought maybe denied meant contract health denied for going into the hospital and then say you needed a foot replaced or broken ankle, and you could get denied then too. Is that the same thing? Am I talking about the same thing?
No,
Two different things.
if we've sent you somewhere and you're in the hospital and we've approved your hospital stay,
Right.
then we've approved the entire hospital
Okay,
stay.
so it is approved.
Yeah, yeah, yes, sir.
Okay.
Yes, sir.
Thank you.
You're welcome.
Any other questions? I guess you're off easy today.
Thank you.
And next is Dr. Grimm.
Good afternoon, everyone. Happy New Year. Trust everyone received our report. And we've started doing some new things in here, and I'm only going to talk about two sections of the report right now, just to let you know what's going on with them, and then if you want to ask questions, either of those components, you can do it as we're talking about them, or any other components or any other issues you have after I get through. We've started trying to get ambulatory visit counts in there for you. You know, we were dealing with ambulatory issues, we were dealing with revenue issues in the transition between RPMS and Cerner. And so if you take a look at page 2 and page 3, at least the way I printed it up, what we did for the clinics in Hastings is we provided a 3-month September, October, November report on services for you. And then on the following page, you'll see a total ambulatory visits. Now, it may appear that there's a significant decrease in services when you look at it that way. And what we are still working on is determining how to report things. What happened, or what is reported in that graph, and you can see below that patient visit definition has changed as of August, whenever we switched over to the new electronic health record. If you take both pharmacy and dental visits and add it to that number, that 56,000 number, you'll end up with 91,968. And so it was not reported the same because of the way the reporting comes out in Cerner. And so we're talking amongst ourselves about how to start reporting things for you in the future. Do you still want to see a 3-year back look like that, or as we're getting into this new system and have the ability to be more granular about how we do things, would you like to see different charts or things like that? And so I know whenever I first took a look at that one, it startled me, and I wanted to assure you all that it's a change in the definition of an ambulatory visit, and the fact that dental and pharmacy are in different packages. And in the past, dental was reporting into RPMS too. So that's part of the issue right now. but we have not seen a large drop-off in services like that chart would lead you to believe. Then I wanted to talk about the third-party revenue, and that's really the next three charts, if you will. The one at the bottom of the page, and then the two on the other page. I'll let you get there and take a look. So you can see that we have a little drop-off on what is reported on the Tribal Council report. This is October's year-to-date, so it is the first month of the year, and it is a full month to take a look at. So you can kind of see prior years and this year, and same way on the remaining two charts. There's going to be a difference also in the way we report this data to you, and we need to talk about that with you, and we're going to have to we may need to do some things to much like the ambulatory report, this revenue report is different. In the past, these past year reports and what we reported to you for a number of years past was just cash basis reporting. Whatever we got in the month of October is what we reported to you. What we got that month, however, was probably from at least 30 days back, and maybe 60 and maybe 90 and maybe some 120 that we were dealing with. And so if it came in that month, we reported it, and you saw it as a October cash balance on our revenue. Also, not only is that have problems, and probably most of you know the problems. I mean, you can have sort of a slowdown in a month in services, but it's not reflected. Also, if we get behind in coding and billing, which sometimes happens, and we do something to catch up, all of a sudden in a month you're going to have a big, spike in our revenue that's not really explained by the workload in that month. So in Cerner, what we're going to be doing is reporting on an accrual basis, so whatever services were performed in that month are going to be reported in that month's revenue. And what we are not really good at yet, because we're getting used to we used to do that on an annual basis with the tribe, for the tribe, especially for the audits that we had to do, the tribal audits, the external audits that were done. But we just did it annually, and over the years we had worked out the percentages that were necessary to know of this much outstanding Medicaid money, what are we likely to accrue in that fiscal year. Same way with Medicare and private insurance. Now doing it on month-to-month basis, there are write-offs like deductibles and co-pays and contractual arrangements between the insurance company and the providers. And until our finance people get pretty good at estimating what is out there and what we think we will collect with that, our reports are going to look a little off. And I can tell you they are being more conservative than probably necessary. And so it may look for a while like our revenues are a little less than what we truly may end up collecting in that particular month. One of the things I want to assure you is that there aren't lost charges. When we started Cerner, it's an industry practice to wait 30 to 45 days for the data to start getting in and seeing how it looks before you start billing. And it was the last thing we implemented as far as that new record was the third-party revenue or the revenue cycle component. And we were seeing issues in some of the billings and coding and things, and so we waited, and we've been working on those. Been working very aggressively and very diligently on those since we started dealing with that. And so we have the ability now to see much more detail about why a bill has not been let yet, why we're holding it, and there are a host of reasons. And someday, if anyone's interested, we can show you the detail level of all the reasons, you know, why something might be held. I don't think it's anything you'd ever want to see in this report, but maybe discuss someday. But the thing to know is that we haven't lost any billings. We haven't lost any for time reasons either. We're keeping a very close watch on if an insurance company says you only have 6 months to go out, we're going to make sure that whatever we're working is done within that 6-month period. So, and we think, you know, I'd say in 6 to 9 months maybe, that, you know, hopefully we'll have things worked out. But what we need to try to do is make sure that from now on we report things in an apples to apples comparison for you, so that, you know, you won't see any sort of big drop that startles you, like it startled me the first time I saw it. So,
Counselor England?
Thank you, Madam Chair. Dr. Graham?
yes, sir.
Since you're on this third-party billing, I have a question. A constituent asked me about it. Is the Blue Cross and Blue Shield, are they not accepting contract or third-party billing through our clinics?
You know, I'd have to look on it individually, Counselor, to see for sure what you're talking about. There are a number of issues that have changed with, they sometimes change regularly, but one of the Blue Cross plans that was under the marketplace, the federal marketplace, is no longer being sold now. And it was a plan that many, like 90+% of our citizens that were eligible to purchase, you know, insurance out there purchased, and so it's no longer there. And sometimes local providers that accepted that plan are not accepting the other plans that Blue Cross has put on the marketplace. So that is a sort of a global thing I'm aware about that has happened. To the best of my knowledge, when we have billed, you know, Blue Cross for things, they have paid us. But
I mean, did that change as of January 1? Or?
yes, I believe
Okay,
it was
so
as of
it's
January
the same
1.
issue that I'm hearing.
Yeah.
Are we going to keep an eye on that to see if?
Yes, we are, and we've, as soon as we knew about it, I don't know if it was a couple of months, we knew about it in advance because they were starting to announce what was going to be, you know, what they were going to sell or have available January 1. That when we saw that the plan that most of our citizens were seeking was no longer on there, you know, we've had meetings with them, asked them about it, and we're going to try to do the best we can to try to ensure that local, you know, healthcare providers and others end up being some of the network on, you know, these other plans that they have. But yeah, it's a concern to us and something that we're working on right now.
Good, I'm glad you're aware of it then. Thanks, Dr. Graham.
Counselor Lay?
Thank you, Madam Chairman. Dr. Grimm, I'm noticing here on the, show you the page. Your pages and ours are different. That
Oh,
third-party revenue by clinic, I noticed
Yes.
that Oshaleta is going gangbusters. They
yeah,
got
I
that
mean,
on the
I should have said
back.
that's the only one that's up.
I just want to point that out.
Yes, I apologize for that. Whenever I looked at it, it's like, wow, Shalata's up. Everyone else is kind of down from,
One of the other questions, when you know, on this page, I think, which is your two, I'm not sure. You're ending 2016, or 2016 is down on the ambulatory visits and the third-party collections on the clinics. And the next page on Hastings. You're saying that's because we're not including the dental and the pharmacy?
for visits, that's why the visits are lower. And if you add in those two other sets of visits, then it goes back up and is still on a upward trajectory. On the third-party collections, it's not that we are not including them, it's the way we are reporting now versus the way we used to. The way we used to report was anything collected in that month cash-wise, we just put on that report and said, here was the revenue for October. Now, it's only going to be the services that we provided in October, how much have we collected on them? And how much do we estimate through the accrual process that we will actually collect of what is still outstanding in accounts receivable or billing if it hadn't been billed yet, or coding? And so as our people are starting to do that on a month-to-month basis, they are being very conservative, is what they've told me, as to what they think collections will be. And so we think those numbers, both at the clinic level and at the hospital level, are going to be higher than what you see there. But right now, that is their estimate. Plus, we do still have some outstanding services that have not yet billed that are in this queue that we're working just due to startup reasons.
And that's a different method of accrual accounting, and perhaps Denise and Jack could help me understand a little bit more about that, what we're talking about. You're not doing the month to month like you did?
Correct. In the past, we just reported cash.
Right.
It shows up in our bank account as of that month, no matter when the service was done.
So we're 2 or 3 months behind, or 1 month behind?
It's tough to tell right now. There can be, and I don't have that report, but you know, once you bill, there's the 30-day, 60-day, 90-day account receivable, and you know, we are and will be tracking that, but we still have some bills that were in that first queue that we set aside because we saw problems that are needing to be billed. And so they are working that, you know, very, very hard right now. And so it's difficult yet for me to tell you, you know, that we're behind how much or X dollars worth right now, just because of that accrual process and what'll be taken off when the thing gets billed. It may be billed at, I'm going to be simplistic about this, $100, and especially at the first of the year. If a person has co-pays and deductibles, you know, we don't charge co-pays and deductibles, but the insurance company will deduct that off of that $100. And so now we owe 70, or, you know, it got billed at 100, but because of the patient pay, it went down to 70. And then because of contractual arrangements with providers, the insurance company, even though you bill 100, maybe they only pay you 30. You know, and so all those adjustments that need to be done are having to be done by our staff now on a monthly basis to accrue the amount we think we actually are going to collect. And until they get better at that process too, and we have some history with the new system and the new, you know, the providers from month to month, it's going to be, and I think they're going to be conservative for a while until they know for sure that they are getting more and more accurate with what they predict us to collect.
So 90 days from today, you'll know what happened this month?
I would say for the most part, yes. And maybe it'll get better over time. I mean, as our bills get better, you know, and not all people are going to wait 90 days to pay us, but if we get something back and we don't agree with what they submitted, you know, maybe because something wasn't described well enough by us or whatever, we may challenge that and ask for a little bit more. And there may be little things like that hanging out, but the bulk of our things we hope will be worked in 90 days. I mean, we have goals for all those, you know, we have metrics for all those things in the third-party revenue process.
Got to keep us up to date.
I will. And we know you've been waiting to see this, and even though it's not, we don't feel, you know, it's 100% the way it's going to turn out actually in the way of collections, we wanted to start getting it out to you, and we feel it's conservative so that it'll actually end up being higher. And that's, I think you'd rather us be that way than promise more than we can, you know, bring in, so.
Eventually, in 90 or 120 days, eventually all that has to equal out at some point. And we can look back and see that you got what you thought you were going to get. Is that what you're telling me?
That's the way I understand it right now. And for those finance and accountants out there, you can tell me, they can feel free to say, that's not exactly right, but the way I understand it, there are credit and debit entries at the end of each month for accruals and what you end up actually getting, and you carry those, and eventually they get posted back to the right month where the service was actually performed. And so I'm not sure how far out we'll need to go because we just haven't done it like this. So before we can say, okay, for October, now we know this is like about all we're going to be able to collect. And we have written everything off appropriately. We've been paid appropriately, for things. Not sure how many months we'll have to go before our finance people feel comfortable that each month is on a cash basis, if you want to go back and look at it that way, if you will.
So they can book it on a month-by-month basis. Okay, thank you.
Counselor Taylor?
So we're not going to know, okay, these figures that are reported as collections are not in fact the amount of money you took in?
Not yet. They are not. They are the amount billed and what has been collected to date. And to the best of our people's abilities, the write-offs that they think will, need to be made to the services. I mean, one of the big things, if you were to take a look at, what we generated in the way of bills for a given month, 40 to 50% of our population right now is uncovered, with a third-party revenue. So 40 to 50% of what we show as billed revenue, or as realized revenue, not billed. I'm probably not using the right terms because I'm not an accountant, so feel free to correct me. What shows up on our bills, if you ran a report, it would be way higher than what we're ever going to collect. And so they initially start writing off those that don't have insurance. And then they start the billing process, and we do start some collections, but we just haven't yet got to the point where with every insurer that we have, we can say on this $1,000 bill, how much do we have to write off? And that changes over the course of a year or two after a patient has met their deductibles and that sort of thing. So, and then sometimes fees are changing, regularly. So we just haven't got good at that part. And I don't know if I answered your question or not.
So are we going to be shown the aging accounts for, what is out there that, is that going to enter in, or are we just going to take what accounting thinks we're going to get?
If you want to start seeing, 30, 60, 90 aged sort of things, we can do that. What our finance people hope and our billing people hope is that eventually they'll get, accurate enough that I don't know what percent is acceptable, 5-10% swing in that number up or down. But the problem is it may or may not ever exactly equal these prior 2 years that we show you because of the way we did it. It was just cash. And to the extent we were caught up and all those sort of things, then, it's about the same. But if we ever got behind, or we had some months where we really pushed hard and made people work overtime to get all the billing and coding done because we were getting behind, those kind of swings that you see in certain months, hopefully we never have those again. I'm not going to say we won't have to do some things like that, but so I don't know how long it'll take, and if our finance people were here, and if they are, somebody speak up behind me. I don't think they are, but I'm going to, I'm an optimist, but I'll guess 6 to 12 months, probably a year cycle that it'll take them to get to know the different insurers, and then the cycles of co-pays and how much deductibles people have that we aren't going to get anything until that's met. And in the past, as we did it at the end of the year, we just had percentages that we used that we learned were accurate over time, accurate enough for our auditors that came in and audited the tribe's books, because they studied it very hard with us. It's something that got studied very hard. And so, I'm not going to be accurate, but say for Medicare, it was 60% of what was billed. So they felt comfortable that if something hadn't been collected already, but it was provided by September 30th, and we had it sitting out here in this account, if we took 60% of that, it was a very accurate estimate for the accruals, for the year-end revenue for the tribe overall. And now we don't have those kind of things in this new system, and to be able to do it monthly like we are now. So it's just going to take a little while.
My guess also is that 2015 was probably unique because of the insurance marketplace. And then, that's just a comment, but my question is it a Cerner requirement that we go to accrual accounting, or was that something that our health system came up with to switch from cash accounting to accrual accounting?
It's something that we wanted to do, and Cerner made it easier to do. We feel like
It's actually our decision to go to.
Yes, we feel it's a more accurate way to show you, what we're doing month to month, because it is based on the services we provide that month, and not the, the ebb and flow of the workload of coding and billing. It really, over time, it'll start showing you, when we compare prior year, it'll really show you how we did collection-wise, once we've been into this sort of reporting for 1 year and 2 year and things like that.
We'll keep an eye on it and visit again summertime or something. Thank you, that's all I have.
Counselor Byrd?
Yes, this is for Secretary as well. For a while, it's going to be a nightmare for our budget to make sure that we're balancing our budget. And we do have internal audits that still take place with amongst the tribes, is that correct?
Yes.
So, Lacey Horn and her staff is informed that these issues are going to be brought up, and I hope you've discussed this in executive directors' meetings.
We have discussed it numerous times with finance and in executive director meetings, and Lacey and her staff have been meeting with our finance staff and Connie regularly, to keep an eye on the way this is going, because it is different, than the way we did it before. But in the past, we uploaded data into the Lawson financial system weekly. Now daily uploads go in. It's making the tribe, more aware of the things that we're doing now on a day-to-day basis as opposed to weekly. I don't know that everybody feels comfortable yet, because we're all getting used to this, but everyone's very aware of it and being kept up to date and watching it very closely. And Secretary of State, I don't know if you want to say any more about that.
I think you've put it correctly. We're very much on top of it.
We just returned from the intertribal tribal council meeting, and it was unusual. In years past, we didn't see this many state agencies or state groups in line to see the 5 chiefs, and everyone's in line to see if they could get some type of contribution or support from the 5 tribes. And that lets you know how the situation, the state is also in. They're in a financial predicament as well. We probably have some cuts here facing us, but if we're prepared for it in other ways, then we just have to move forward and communicate with all the different branches, make sure we're all on the same page. Thank you.
Okay, Counselor Baker?
Thank you. So basically, instead of third-party collections, we're getting third-party billed after adjustments for deductibles and write-offs. But it seems to me it would still be easy to give us the actual cash collections for the month, because that should be a readily available figure.
It is. It is. I just don't have it here in this. That's something we can do too. We wanted to start moving to this sort of, get our whole system used to this sort of reporting. And we made the move, and we wanted to see what you all thought about it. And, if you have some concerns or want to see other things, let us know. We've always tried to be responsive to your requests.
Excuse me. Well, could we see both the cash collections and then a separate one for the amount that's billed? Would that be possible?
I think it is.
Good.
Thank you, Madam Chair.
Counselor Buzzard?
Yeah, and Jack Baker just asked a question that I was gonna see if we could do. Along with that, can we see any comparison from a year ago and where we are? I know that may be asking a lot, but what you're looking at now is not the pharmacy and the dental. But you have those records from the past year.
Yes.
Just take a look at that, because I was really alarmed, Dr. Grimm, when I saw this report this month. But Mr. Baker had asked the question that I wanted to see if we could do. The other thing is, not so much on the billing part, because I think I've heard most of this, the questions I had, and probably more than I had. But the other thing is some of the problems that we're getting that could affect the overall billing process, which, one, I've had some calls about coding. Machines, and this is at a J clinic, that's where I got my calls from, is they get kicked off of coding for hours sometimes. And I don't know how many codes you can put in an hour. I would say 30, 40, maybe 50 an hour, but if you get kicked off, and I don't know how many codes we have up there, that's a big problem right there. So anyway, you might want to take a look at that and see
We
if
will.
there's anything we could do to fix it. Because I don't know if it's the server that's kicking them down or what the problem is, but they're telling me they're getting kicked off and they just sit there, they can't do anything. So that could be a problem.
Okay, we'll look into that.
And the other thing is, and these are just comments now that I'm going to add or tell you, and I guess I blamed a lot of this on some of our revenue failure is the amount of patients that our providers see. Because I know we used to see 18 to 22 a day, and now we're seeing only 9 to 12 a day. To me, that's half of what we were seeing. The other thing is I've had a lot of people that are on Center Care. They try to go in, they can't get appointments, they just go to another doctor. So we're losing those people that's got Center Care and even insurance. People that have full coverage insurance called me the other day, said, I hardly had full coverage. I went to the pharmacy and called on Tuesday, and they said, come in the next day and then have my medications ready. They went in and still wasn't ready. So he said, I'm considering going to another provider so I can get services because I can't be without medication. These are just, we're council members, and we're gonna get these calls, and I'm just passing them on to you so you'll know what's out there. I think the main thing is, I'm afraid we're losing patients because they're gonna go to other providers because they have insurance, they're fully covered. And you would be surprised at some of the elder people that has insurance. You would think in J that we don't have many people have insurance, but most of them do because they're either county workers or state workers, those type of people that have full coverage. But I think if we see what Councilor Baker had proposed a while ago, I think that'll help us to understand a lot. Because I'm not up on accounting like some of the people are that's doing the accounting for you, but those numbers would help a lot. Because I was really concerned when I saw the numbers from this month's report. And I think you've done it. And I'm glad to hear what you said today. Probably saved some of these questions if we'd have known 2 months ago what was coming down. And maybe you didn't know at that time. And some of this, I know it's learn as you go in some of these programs that you get because I've dealt with those too. So some things you can't get them all the first time around and it takes some policing to get it done. But anyway, those are some of the concerns that we have at the J Clinic. And I don't know if the other clinics are having a coding concerns or not. But the last thing there is same-day appointments. We just can't seem to get same-day appointments for people up there. I know providers, we're probably short of providers. Thank you for explaining. I understand a little bit better how we're doing things now.
You're welcome.
Thank you, Madam Chair.
One of the things I might say, not to specifically get into productivity, is that though we have been watching, and our productivity on average across the system now is back to where it was, prior to us beginning this new electronic health record. And it's not to say there aren't persons or spots that are a little lower, but our productivity is back up to at or above, where we were. So we're excited about that. I mean, it's tough to learn a new system. The other thing is we're expanding a number of clinics. I'm anxious when Jay is to get open to see what we can do about, making more availability for patients so they don't go elsewhere. And we have added some additional provider positions to some of the clinics that got expanded. And I'll look into the same-day appointment issue.
And I have a follow-up question. I've asked Ms. Davis or Connie about a pediatrician at Jay. I wish you put that down on your radar because
Okay.
as what's happening now, what I understand, a medical director is actually seeing those patients. And I know with her being a medical director, she can't see as many patients as what the pediatrician used to see there. She was a full-time pediatrician until a year ago. And what I understand, the pediatrician told me that she was seeing, you know, all the patients 18 and under. I know that has dropped off because being a medical director, she's got other duties to do other than see patients. Pediatrician is really a thought that comes to my mind because I've had a lot of calls on that. The other thing, and I don't know if this is in your realm of scope of work, Dr. Griffin, but cameras at the new clinic in Jay. I talked with the contractors and he more or less told me that it's kind of up to the Cherokee Nation, and I don't know if it goes to the IT department to get those installed, but we really need them because there's been a couple of people that's tried to break in that place already. I think we just need to put some priorities on getting cameras installed.
I'm aware of that, and we've been communicating with the right people to try to get them done as soon as possible.
That's it. Thank you.
Counselor Thornton?
Yes. Have a lot of questions. I don't think I'll ask them all today. But about filling prescriptions. I get a lot of complaints just like everybody else does. I know with my own experience, we've got problems. I called mine in to be mail delivered on the 5th. As of today, it had been delivered. Tomorrow will be the 4th day I'll go without medication. I was told that they fill a prescription on Friday and they mailed it out today. So I don't think that anybody is really realizing what's going on. It looks like to me it's just going in one ear and out the other over somebody's head. And what I would, and you may already be doing this, I don't know. But do you have anybody on the weekends filling prescriptions?
You know, I can answer part of that instead of answering any of it, though. I know Jeff's here, so I'm going to let him help me respond to that.
Dave, the information you were given today is correct. I got the email today and I looked into it just to follow up as well to see where we have issues. And unfortunately, I couldn't find when you actually phoned it in, but you said you phoned it in on the 5th. I did notice it was processed on Friday the 8th and checked the refill center, and it was, the mailing label was printed this morning, which means it's shipped today.
I got the call-in date on my phone.
Okay. And you know, typically we like about 5 days.
But I'm starting to feel the effects.
5 business days. Yeah, and we don't want you to be without meds. You know. I tell patients if you're that low on meds, bring your bottles to the pharmacy. We'll give you meds to get you
And I'm
by.
trying to be calm.
And Salisol's one of the sites is probably struggling more than the others to make the adjustments. And I've actually got a meeting coming up here pretty quick tomorrow, and we're going to try to discuss maybe some resolutions for that facility as well.
Well, it's in the past, I know 2 months ago, like everyone else, I was sitting down at the pharmacy trying to get a prescription. I'd call them in, and then fill them online, the mail order. And so I went down on Monday. They didn't have them. So I went back Tuesday and they had 2. I went back Wednesday and they had a couple more. And they had the rest of them the next day. That's 4 days of them knowing that someone didn't get their prescription.
Did you phone them all in at the same
thing about
time?
it is, they don't even, you know, people have to sit in there for 2 or 3 hours, maybe more. I know, I've sat there.
Yep, and I know that as well. You know, unfortunately, I know that as well.
Something's gonna have to change.
Well,
And I don't know if it's gonna have to be new directors or
yeah.
that type of thing, but something's gonna have to change.
Well, Dave, you know, I can say that I know they're working
I know
diligently
that.
trying to take care of folks.
Yeah.
And, you know, once again, I know we're gonna have a meeting and discuss maybe what we can do down the south, so. I've noticed improvements at most sites, even
I don't
Hastings
figure
is coming
cell
around.
saw's the only one.
Pardon?
I don't figure cell saw's the only one, because I hear the same thing from people that visit Muskogee. But,
I'm hoping it's improving some. I'm seeing some improvements. You know, waiting times, I'll use Hastings as an example. When we first started this system, you know, it was 5 hours or longer. And that's going from, you know, what we had before. And now we're down to processing most of the prescriptions. The days we have we're fully staffed. We get most of the day's work done that day and process our refills. So things are improving.
your doctors, your nurses, the people that's running computers, they all blame it on that new system. And they say it didn't work 2 cents. And they didn't really helping them that much more. I was talking to my doctor when I went and saw her. She said, "Do you want me to fill this prescription? You wait on today?" I said, "No." I'm not going there, because it would have been a long time.
Yeah. You know, and
They may say they filled them, I'll come back and it won't be filled. But there's lots of problems there, and somebody needs to sit up and look at it and take care of it. Now, if you don't have anybody filling prescriptions on the weekends, you know, I can see where you might catch up, but I don't know, you may have somebody already doing that.
we know for the clinic. You know, their processing is all done during the week. And then it's resumed again on Monday.
I get so many complaints. Plus, I get complaints about, we've got people with cancer that are going in and to get their treatment, they're having to wait 4 or 5 hours to get their treatment. And the one person I know that did that she's going to Muskogee. And one day she called me. And it seemed like I called a certain person, and within 30 minutes, they had her in the office. But we shouldn't, our people, especially with cancer, and they're not going to live very long, they need to be treated right. And if they have an appointment set up, you need to take care of those people when they get there. That's the way I look at it. Because most of them aren't going to be with us very much longer. Somebody needs to start really looking into the health system. I know I'm not the only councilman that's sitting in this boat. I hope it's not a real small boat and all of you are in that way, because it's long to see. But I would really appreciate it if it quits going through one ear and out the other, and it quits going over the head, and somebody takes hold of something and takes care of business. Now that's, you know, Elvis, that was his motto, was TCB, taking care of business. And I'm not so sure if our health department had to need to adopt that. Thank you.
Counselor Warner or something?
Yes, Mr. Sanders, I am really excited to hear that you're going down there, because that's basically all my questions revolved around a lot of the pharmacy. Do we still see a lot of instability between what the doctor sees on the Cerner and what the pharmacy sees? Because now it's come to a point where the pharmacy's blaming it on the provider and the provider's blaming it on the pharmacy. You know, and then, and he mentioned cancer patients, but, you know, you got to throw in the behavioral health patients there, because, you know, if we don't watch that, then you're involved in a lot more individuals, you know, through, you know, marshal services, sheriffs. I mean, you know what I'm saying?
Absolutely.
And I don't know, I mean, what we got, 4 or 5 pharmacists at Salisaw? 5, and we got 4 techs. Okay, when I go into a pharmacy in town at Salisaw, a good friend of mine owns one. They've got 1 pharmacist and they've got 6 or 7 techs. I don't know. You know, I'm just trying to find a way. I'm not saying we're doing it wrong. And also, you know, maybe it's one of those deals where we come down to a point where, I mean, everybody deserves a day off. But right now, I think everybody agrees we're all hands on deck in the pharmacy. And if we can reiterate the fact to those techs, hey, you don't just work for that $1 an hour. You're just as important as the doctor, as the nurses involved in that patient's care. And if they would get on board with us and go all hands on deck, maybe there's some sort of incentive that we can give them. Look here, we need you for 3 months to not take a vacation. We need you. I mean, I would be, if I'm going in that, but I'm speaking for myself, if I go into that field, then I'm willing to go above and beyond and do, and that's the type of people I think we're looking for. So when you have that meeting or whatever, if you need me to be there or anything, I would love to if I can schedule it. If not, I'd just like for you to reiterate that point that, and I know you feel the same way, that we need to be all hands on deck on this deal. And I understand that we're trying, but I've received several calls, and I know Counselor Thornton gets a lot of the same ones that I get, the same type and everything. And, and I know you guys are looking for, because if I can think of a few solutions or whatever, or possibilities of a solution, I'm not trying to blame anybody. It's past the point of who cares about the blame. Let's look to the solution side of this thing. You bet, and I'm willing to work with the team, so.
Yeah, and that's my comment, to you and Councilor Thornton and everyone here too, is we just need to continue and move forward as we're doing now, looking for solutions to problems that come along. RPMS was an old system, but, it took us a lot of years to get RPMS to where we wanted it as well. And, we're trying to transition this system into an arena at a faster pace. We don't want to wait all those years to try to have what we before, so we are continually looking for improvements and ways. And as you mentioned, there's still things we find out between providers and pharmacy. And some of it is electronic, and so we say, hey, here's the problem. We specifically write things down, send the information to Cerner, and then they look at the programming and fix the problems. And that's what it's going to take a while. Well, I still see that going on. Unfortunately, it's not a flip the switch and have exactly the same you have like we had hoped, our visions, but I knew in my mind that I've been through a couple of transitions and have been one that's been that way yet.
Right. Well, believe it or not, I've talked to several hospital administrators, and they say that Cerner's a Cadillac compared to what they have. So, I mean, whether you want to, I don't know what year it is, but I don't know what year, but how many miles it's got on it, but anyway,
Well, this is a new one. We don't have it worn out
okay.
yet.
All right.
I mean, I would add to what Jeff said too, just so everybody knows, and Counselor Thornton's comments, that we have, since we realized the problems, which were pretty immediate, with pharmacy, we have been dissecting that process. I mean, our processes, the software processes, and where it goes, and we've been working with Cerner, we've been working with our pharmacy staff, our providers, whenever issues touch them, and they have to do things, and we are doing a lot on that problem, and we've been working on it a while, and it has gotten a little better. People have noticed, and then something will happen like what happened with Counselor Thornton, and he calls his prescriptions in, and for whatever reason, it gets delayed to sort of the maximum extent we ever like to see there be a delay. But I just want everyone to know that we are not working on this. We're working on that pharmacy issue very, very hard.
Now, we do have some, to add to that, we've got some changes coming in February, working with Cerner on that I think will help the pharmacist processing speeds upon that. We've implemented 2 changes at 2 sites, experimenting with some communications between providers and pharmacy. And it's working out pretty well so far, and as soon as we get that process solidified, we'll implement it to the rest of the sites, which what we're trying to do is save time with processes each step. The more time we can save the pharmacy team from having to do data entry and verifications and running down problems is the other thing. This problem feeds upon itself, because when we pick up the phone, it's not a 2-minute call. It's usually a 5 or 10-minute call. We're trying to help someone out, and that just takes more time. We're seeing fewer of those now, which is helping us some. So.
Thank you. Thank you, Madam Chair.
Well, I know that before this new system went in, I have got my medication the next day.
Counselor Taylor?
This is not on pharmacy, so if
You guys have any
anybody
more questions?
has
Yeah, we have
any
more
other
on-
questions on pharmacy.
Crittenden?
Yeah.
Are you on pharmacy?
No, ma'am.
No, ma'am?
Okay,
Okay.
does anybody,
Walking stick, you on
Dave?
pharmacy?
Cerner.
Cerner, but it's not pharmacy necessarily?
It's in.
Okay,
it's-
okay, go ahead, Counselor
okay,
Taylor.
Dr. Graham, what my question was, we have got a transfer from Muskogee in dental to replace Dr. Thorne. And my question was, is that a permanent or is that a stopgap solution until we can get somebody permanent?
I'll find out.
Okay, thank you.
Is that
And for that matter, I'll just follow up with Dr. Jones. Don't worry about it. Thank you, that's all.
okay, Counselor Crittenton?
Yes, sir. We had a meeting last week about the, just man killer clinic. Nice meeting. I'm convinced that, I'm talking man killer clinic, that, there's a lack of staff. And, I was assured that we're looking for 2, trying to recruit. And another one's leaving, so possibly looking to recruit 3 providers. And I went by there this morning, and we talked about the drop-in clinic. I can't speak about how things should run or need to run. I'm not educated that way towards the medical, but there needs to be more than 1 drop-in doctor for sure. And they talked about adjusting it, because on Mondays there's just 1. So I'm looking forward to that. But as I was saying about the 3 that we're recruiting, in the recruiting phases, could you give me just an overview, just real brief, the recruiting, just how that works?
Dr. Montgomery? Do you mind giving them a brief overview of how the recruitment process works?
Well, I think the important thing to point out is that there's a dedicated staff, and I think Ms. Wycliffe has been here before, but we have a
Right.
Director of Recruitment and Retention, Stephanie Wycliffe. She has 3 people under her, dedicated to trying to recruit
Right.
staff. Got 1 dedicated to the clinics, 1 dedicated to Hastings, and then 1 that's just busy all the time with the volumes of information that has to be processed in order to take on applications. In addition to that, though, there are 4 or 5 dedicated web-based places that providers can access. If you hunt, you know where to go hunt. Doctors that want to find a job know where to go hunt for a job. And most doctors now, or not most, but a large percentage of doctors that are out there getting ready to find work know where to go on the internet to find out about jobs. So we have postings on those internet sites for Cherokee Nation, and we've developed a very nice profile that tells providers about our system and benefits, pay, that sort of thing. Then the other thing that we do, you don't drive. Some people like to drive 300 miles to hunt. Some people know their backyard pretty well, and their place about where they live, they're a good place to hunt. So we know that the best places to find providers are the local places. OSU, we've established relationships with the University of Arkansas in Fayetteville, and we're trying to develop relationships with OU in Oklahoma City and in Tulsa to try to get those residents that are just finishing training to come work for us. And so those are going to be our best bets, and that's where we've had the most luck in the past, is getting those doctors that are close by, that know us, and we get to know them, and then they come to work for us.
So it's a day-to-day operation, the recruitment?
It is a day-to-day
Okay.
thing, yes. And Ms. Wycliffe is doing a great job of making some changes where we do a better job of tracking who contacts us. If somebody calls us and we don't call them back, we're not doing a very good job of recruiting. So she's doing a very good job of keeping a log of all those people who touch us, contact us, so that we're sure that we call them back, express interest in them, and make sure that they know we want them if they're interested in us. So that's a brief overview of what we're doing. There are other things that we do in the way of recruitment, but those are the core efforts that go into our recruitment.
Thank you. And like I said, it's going to happen. You got people on it. And that was just my question.
Yeah.
So thank you. I have one other question you may be able to help me with. Constituent there in Stillwell stopped me in Walmart, and I don't know much about the denture side of it. He got dentures. He asked me, seems like he said that Cherokee Nation covers one realignment, is that right?
I have to defer to Dr. Jones on that.
Okay, and he was concerned, as well as a lady that just happened to be a former council person, and they've heard that a lot, just concerned about wanting maybe more than one realignment, taken care of, because I don't know how that works either, but I've heard it takes a few fittings, if you will, for it to get just right. And this particular guy was in a kind of a bind financially, but that was his question. If you could look into that for me, I'd appreciate it.
I'm going to say one more thing about the recruitment within Cherokee, and I hope you don't mind me going back. Most of you probably know, but some of you, if you don't know, the Directed Studies program here at Cherokee Nation is also a very important tool that we use to find people that are interested in Cherokee Nation, and people that get support for their education end up having a payback that leads to them coming back to workforce. That's very valuable. And the other obviously important tools are the IHS payback. We have a lot of providers who are working for us in the way that we kind of recruit them, that we get them involved is through their IHS payback. That's another big important resource for our recruitment also. We'll look into the denture and the alignment.
If you'll get me a name and a phone number, we can look directly into that case, and we can talk to you all about the rules at some future meeting of that program if you'd like to.
Thank you. Thank you.
Very good.
Thank you.
Councilor Watkins Tickle.
Dr. Grimm, there's been, I talked to some of the doctors that they're leaving, and we also talked about maybe doing some exit interviews with some of them to improve our program. Some of them mentioned that the administration was kind of getting down on them on their number of doctor visits. I know some of them are 7 or 8 a day, and you guys, I guess, were saying the Cerner was the reason slowing things down. Well, I talked to Connie, and she's like, well, there's people that use Cerner or St. John's, and they see 20, 25 patients a day. And I think we have other doctors that see a high volume of patients. And then there's some doctors that see a low volume of patients. Well, whenever I was processing all this, it's similar to me as giving somebody 100 addition problems and then someone 100 trig problems, and say, all right, course person that's doing the addition problems, they're going to get 50 of the 100 a day, versus the trig, that might get 7 or 8 done a day. And I guess it's similar to your patient loads. Some of them might come in with a sinus infection, and there might be a little more complex, So when we're doing these numbers of visits per day, are you seeing that these doctors that are doing 7 or 8, are they mild cases or are they pretty complex?
I'm not sure if I can answer that or not, or if Dr. Montgomery wants to try. We have providers that are in, say, urgent care or ER that are trying to see relatively simple patients' needs and try to get them in and out. And then there are complex patients that end up showing up at urgent care or, and especially ER, and end up taking quite a bit of time. On a day-to-day basis, we've tried to ask the providers, we've been trying to work on a scheduling mechanism that would try to balance the complexity with new patients with follow-up visits that should be quicker. And you can't always do that every day either. And some patients have panels that are very complex, and we have...
just like the doctors that are leaving and stuff, I know I talked to some of you guys, and you're like, well, they're not seeing enough patients. And my thinking is it because of the complexity of the patient, or are they just not doing their job? Are they simple, mild cases?
Again, I'm going to ask Dr. Montgomery to comment. Currently, you almost have to look at that on a case-by-case basis with the physician and see what complexity of patients they're doing. You can look at the coding a little bit to see complexity, the coding that you use for billing, the more complex the patient and the more things you address, the, higher and different the coding is. And we're starting to look at other avenues of trying to assess that too, with our providers, to see if there's ways we can there are ways available, and if we want to use those sort of things to measure the complexity of patients in a different way than we have in the past. Dr. Montgomery, is there anything you want to say, or?
We do have a tool. It's a way of trying to assess the severity of, or the complexity of a patient's problems. When doctors see patients, they put in the various diagnoses that apply to those patients. So if a person is 19 and comes in with a sore throat, they'll walk out and they won't have anything on their electronic health record that says they have any kind of chronic illness. If you're 70 and you've had a heart attack, you have diabetes, high blood pressure, you've had an episode of heart failure, the doctor will put those diagnoses into the electronic health record, and you will have that information aligned with you, and we can then go in the computer and find patients and their complexity of illness and develop lists of those patients that then we can attribute to providers. When you attribute those patients to a provider, we call that empanelment. When I was in practice, I had a panel of about 2,000 patients, and they varied in complexity. And I could go back through my record and find out how many of them, what percentage of them were really complex, what percentage of them weren't so complex. Our clinic administrators and medical directors are assigned or asked to try and distribute patients to their providers so that the complex patients get distributed evenly among the providers. Now, it's not perfect. There are some doctors who will tell you, I've got the most complex patients and I've got all of them. Well, the goal, though, is to try to spread that load out so that not one provider has all the complex patients. Now, you asked about the same-day doctor. There is a doctor, though, in Stillwell. All he does is see same-day appointments. He doesn't have any empaneled patients. So if you looked at the complexity of the patients he's seeing, they may have a lot of different diagnoses, but they're typically just walking in for one thing. So the time that a doctor spends seeing a patient there's a lot of different factors that go into how quickly an appointment will go. Yes, it's how good they are at using the computer. It's also how many things the patient says to the doctor. I've got back pain, I've got a headache, I can't breathe, and then would you refill my 10 medications? That's going to take a while versus I've got a sore throat and can you give me a note for work? That's going to go quicker. It's a very challenging job for our doctors, and I think they do a wonderful job of it. With regards to the number of patients that we ask the providers to see, we try to be very fair, but provide direction to encourage them to increase their numbers. And right now we're asking that all of our primary care providers schedule 15 patients a day in an 8-hour day, 19 in a 20-hour day. That we feel is a realistic number. And some are doing it, some aren't quite there. But we haven't, I think we've tried to send out a message that we understand you're learning the system, you're learning how to use the record, and we gradually move those numbers up. And I think that we've been fair and realistic in what we expect of our providers, while at the same time balancing that very important issue of access. So I hope that sounds appropriate, and I hope that explains.
I'm glad you guys have taken that into consideration. That's good. And the next thing is the Palladium. Are we? What's the status of that? Is that in your opinion, is it broke or is it?
It's still in use. It's still has issues that periodically come up that we try to work on whenever they come up. If a provider or providers have some issues with something on it, then we try to work with Palladium to try to fix them. But it's currently still in use.
Is it saving us money?
Yes.
Okay.
And I'm not sure if we can say exactly what, but I don't know that I've ever asked that question.
Saving money versus if you were to contract out with a doctor, a pain management doctor.
Now that I can't answer. I don't know that we've looked at an analysis like that, but what we're trying to do is to the extent, chronic pain and back and neck issues have scientific evidence behind the best treatment, we're trying to use that and starting out with more conservative therapy if that's what is warranted, than going straight to injections or surgery, unless that's really what's warranted. based on what's, found in the clinical exam and in the literature that's being used, to make some of those decisions about where to send that patient next. So we think it's prevented some things that may not have been good practices for our patients. Probably started us on a road to more conservative therapy with patients initially, where appropriate, and some of the bigger complaints are just the paperwork you got to do to put it in action. And so whenever we do have issues arise, though, we try to get on top of them with our providers, talk to them about it, and then work with Palladian to try to get them fixed.
Okay. Thanks, Dr. Graham. Thank you, Chair.
Councilor Lay?
Thank you, Madam Chairman. Dr. Graham, do we have an optometrist at Oshaleta yet?
Not yet. We had one, but he ended up going somewhere else, and so we're working on that again. He ended up taking he wanted to go there because that was closer to his home, but his home was actually in Stillwater, and so he found a place even closer to his home. So we lost him for, very personal reasons like that. Just wanted to be closer to the family.
So I got to see him one time and he left. I don't understand what's Brett Hayes, have you figured out how to do the diabetic shoes yet for me?
Yes.
For our patient? Yes? Is it a done deal, or?
What's in the process? We're going through doing contracts, and it's going through with the podiatry and diabetes programs and the primary providers. So, yes.
We've been in the process for.
Well, like the patient we talked about, I've figured out has an appointment February 1st with podiatry. So
Okay.
it's a maybe on fast process.
Okay, thank you.
Sir.
Thank you.
Councilor Garvin?
Thank you, Madam Chair. Brett, I need to see you before you leave. Dr. Graham?
Yes, sir.
About an hour ago, I think you was talking about insurance, and I think you said that 40% of our people do not have insurance. Is there anything you figure out that might help? I know IRS kind of gives them, y'all kind of talked about it?
Yes, sir. We have what I'll call a very aggressive approach to the Affordable 4. Patient benefit coordinators in each of the facilities, which prior to that law becoming effective, mainly dealt with patients that needed to get on Sooner Care or Medicaid or Medicare, when that time rolled around. Whenever the new federal marketplace came into Oklahoma, we trained all of those staff to be certified application counselors. And we don't really report those numbers to you every month, but actually we're doing really good. And in fact, better than many tribes, if not all tribes in Oklahoma, about the number of people that we have helped sign up and answered questions to. Not only do they help them with signing up, but if anyone doesn't want to sign up and they want to get the paperwork, to get the number you need to put on your taxes that says, I am of Indian heritage, so that you won't be penalized. We help them with that too. So we're doing really good on that, and we're constantly looking for new things. I mean, we're exploring today, as a matter of fact, in a meeting after this, the potential to apply for a grant that would help us do more outreach in locations other than our hospitals and clinics for Sooner Care, for kids in particular, to make sure kids are covered. And then sometimes when you get them, their parents end up finding out they're eligible for things. So we are doing a lot. I feel like in that realm and in the billing realm, you can always do more, though. We're not satisfied that we're doing everything we can, but we are working on it very hard.
Do you think it'd be profitable if the tribe got involved and helped them get this insurance?
Paying for it, you mean, for people?
Money-wise, premiums.
I don't know. In most cases, it might be. You know, if a patient has a number of things that they're going to have done throughout the year, or especially surgical or cancer, you know, then it might be worth it, you know, financially. You know, if it's a young person, you know, that rarely uses our system, financially maybe not, but you never know when someone like that's going to have some sort of catastrophic, you know, incident or accident. So we haven't, I mean, we've looked at it a little bit as a system. We've kind of done a little bit of costing about it, but, you know, we've initially tried to see if we could go out and get a lot of those people that were interested and wanted it, and many of them end up with very, very low premiums, 25 cents a month, $1 a month, you know, $2 a month, $5 a month, and are so excited to get it, and, you know, it's not a hardship on them. We've been concentrating on that, and we talked early on about, you know, are there others that we might want to go for that we would fund, and, you know, it's sort of the whole open the door or open the floodgate and what happens, and then how do you decide who you're going to pay for? Is it only those that need orthopedic surgery or have cancer or what? You know, and then the insurance companies would run when we started coming if that's only ones we paid for, but they'd still have to, you know, sell us insurance. They can't deny people for, you know, any pre-existing condition these days, and that's a good thing, but we just haven't really gone down that road very far, Counselor.
Thank you very much.
Pardon me. I have a, not a gripe, a praise item. I got a phone call about 3 weeks ago. My son had cut his leg with a chainsaw. And I just thought, right off, man, he's down to the bone and everything. So he came to Hastings. He got him in there at 2 o'clock. His leg was cut right above the knee, cut about 5/8 of an inch deep. They took stitches in the middle and on the top. He didn't cut the main artery, but he bled a lot. But Dr. Smallwood worked on it. Did a beautiful job. He was there 2 hours. Got to go home, and he works at St. John's. He took 1 day off, and he works nights. He works 6 in the morning till 4 or 5, or 6 at night, 4 or 5 in the morning. But he took 1 day off and went back to work, and he even went roping on that Saturday night.
And he's a tough boy there, tough man.
And he said, I said, well, how's your leg feel? So I asked him that. He said, well, I've been a lot better off having went roping, so I got a cold now. But Dr. Smallwood did a beautiful job. And when they called me, I took off, went to the clinic, and got up there, and I said, my son has cut his leg. How bad is it? Can I see him or anything? He said, yeah, he said, they're getting worked on. So I stuck my head in there and gave him a little high five. He was not great, but he survived, and they did a wonderful job.
Thank you.
And, I was hoping I'd have some complaints, but I don't.
Always nice to get a month off there. Sorry to hear about, you know, what happened to him, but we have some good docs, and Dr. Smallwood is right up there. I'll be sure and pass along the thanks, and I'm glad he's feeling better. She probably would have told him he should have not went roping too, just if he asked, but.
He's well pleased with the work he did, and shows the whole family.
Thank you.
Thank you very much.
Counselor Berg.
I'm just going to try to end at a positive note like Counselor Snell. I want to thank you for your leadership and your concern and how you handle our situation there at our fitness center. You know, we salvaged that facility, probably could have gone another way if you hadn't acted in a timely way that you did. And you know, we had Lisa Pivick there and had Tracy Bluebird and Shirley Goodland and the staff. They really went above and beyond in making sure that place, you know, got taken care of. You know,
They really did.
I don't know how much water we had there, but you made some good calls, so I want to commend you for that.
Thank you. Thanks very much. And for those of you that didn't know, we had a flood at the gym, and unfortunately, it's never good, but we really wanted to get it fixed before January 4th when people are coming with their New Year's resolutions.
Yeah.
And wanting to get healthy, we didn't want our gym to be a reason somebody quit on January 4th, you know, and so.
We were unhealthy for a couple days, and that was about it. So I just want to thank you for that.
Everybody worked very hard, and thank you, Counselor Byrd, for those kind words. I'll make sure they hear it.
Thank you, Madam Chair.
Okay. Moving on to old business, there's none pending, new business, none pending. Anybody have any announcements? Next meeting scheduled for February 16th at 1 o'clock. Motion to adjourn.
Second, or entertainment.
Okay, all in favor?
Find out.
Very good.